glycogen storage disease type 2. Unfortunately, we have Dr. Nawal, the third speaker. She did apologize early, but we have already did the logistics things. It's my pleasure now to introduce Dr. Abir Hamid. She's a consultant pediatric, head of pediatric department in Saudi German Hospital. She will be the moderator of this session today. تفضلي دكتور عبير.
دكتور عبير.
دكتور عبير, unmute yourself.
You can, أيوة, you can hear me?
Mm-hmm. Yes, Dr. Abir, we can hear you. You can
hear you. بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم. Thanks, Dr. Fawzia. It's my pleasure today to participate in this interesting scientific webinar for Rare Disorder Disease Day. It's held under care of Saudi German Hospital, Jeddah. On behalf of our hospital, I would like to welcome our eminent speakers and our dear guests. This is a series of 5 sessions with 2 CME hours for each session. This is the second session today, and we will have 2 presentations, and the questions, please, will be at the end of the 2 presentations. Our first presentation for this day is Pompe disease by Dr. Ahmed Bamaga. Dr. Ahmed is assistant professor and pediatric neurology consultant, pediatric and adult neuromuscular disease consultant at King Abdulaziz University, Jeddah. Welcome, Dr. Ahmed, and please, you can start your presentation.
يعطيك العافية دكتورة. السلام عليكم. I'm going to share my screen. Just give me 1 second, and we'll start right away. طيب, السلام عليكم. I hope everyone can see my presentation. Is it clear to everyone?
Yes.
السلام عليكم. So first of all, I would like to thank the Saudi German Hospital and the organizing committee for inviting me to talk about the Pompe disease. Hopefully, we're going to enjoy the next 25 minutes or so talking about Pompe disease. We're going to talk about a couple of things in Pompe. Try to focus on like a quick case that I have seen, then the history of Pompe disease, basic science behind Pompe disease, clinical phenotypes of presentations, followed by the tests that we usually do to diagnose those patients, and we're going to end up talking about the available treatment for Pompe disease. So please bear with me and prepare your questions. Hopefully, toward the end of this presentation, toward this webinar, we're going to have the questions, inshallah. So this is a case I have seen during my training. This is a 12-year-old boy. He presented with increased work of breathing. He was born at 37 plus 2 weeks to a 31-year-old G1P1 mom. Pregnancy got complicated by idiopathic polyhydramnios. The hospital course itself got complicated by poor feeding and aspiration. You examine the child, and actually what you notice is he had strong suck. It wasn't that bad, but he has decreased or reduced axial tone, very severe head lag, with normal to slightly decreased appendicular tone or limbs tone. He was moving all extremities against gravity and against minimal resistance, so 3 to 4 minus out of 5. And his reflexes were present and normal 2 plus out of 4 throughout upper and lower limbs. So now you are facing this almost 2 weeks old baby boy with central hypotonia and presented to you with decreased with respiratory issues, and he has normal reflexes on exam. So the thing that you have to think about is, one, I mean, is it spinal muscular atrophy? Yes, but I mean, it's less likely giving the normal reflexes. The other differential that you have to, it has to cross your mind is congenital myopathy, congenital myotonic dystrophy, congenital myasthenic syndromes, and definitely, since we're talking about Pompe, metabolic myopathy, and Pompe being the top one on that list. So you thought about Pompe and other myopathies. You did the CK came back a little bit high, 667. It should be less than 250, 300 maximum in newborn. since Pompe is in your list, since as a good pediatrician, you thought about, you asked for an EKG, and that showed actually biventricular hypertrophy. Then you ask your colleague cardiologist to do an echo, and transesophageal echo showed moderate RVH, diastolic dysfunction with increased papillary muscle size. So now you have a hypotonic child, 2 weeks old, with normal reflexes, high CK, and abnormal heart or hypertrophic cardiomyopathy. I mean, it has to be Pompe until proven otherwise. And you did an X-ray, by the way, and the X-ray showed this large heart, more than 50% of the chest diameter, and that's just confirming the echo finding of a hypertrophied heart. So that now it's most likely you have your answer. Then you have to confirm the diagnosis by genetic. We'll talk about diagnosis throughout the lecture. So let's talk about Pompe. So Pompe is we have different names for Pompe disease. So Pompe being the most commonly used name, Pompe disease, but other names, acid maltase, referring to the enzyme that is deficient in Pompe, acid maltase deficiency. And the main name, or the bigger name, or the classic name, is glycogen storage disease type 2. It is a family of different diseases in glycogen storage, and one of them is Pompe disease, McArdle, the other one, Corey, von Gerg, and others. So what's Pompe disease? It's a rare, progressive, debilitating, and often fatal neuromuscular disorder unless you intervene with treatment. It's due to a deficiency in the acid alpha glucosidase or acid maltase enzyme in the lysosome that actually breaks down glycogen to glucose. It's your typical autosomal recessive monogenic disorder. It's not that the genetic behind it, the pathophysiology is not that difficult. It's a straightforward autosomal recessive disease due to a deletion in the GAA gene in chromosome 7. It's usually characterized by accumulation of glycogen because you cannot break down your glycogen in tissues, and that will lead eventually to progressive muscle weakness, loss of respiratory function, cardiomyopathy, and especially with infantile onset, premature death if we don't treat. What's the story behind the Pompe disease? So the first one who described Pompe is Dr. Pompe himself, Johannes Pompe. That was back in 1930 when he was describing an infant with abnormal heart or cardiomyopathy. He did a cardiac autopsy. This is not biopsy. This is an autopsy. And that showed a vacuole in the muscle, the black arrow, and also lipofuscin deposition, which is like glycogen deposition in the muscle. And then he came up with this possible Pompe disease. But it wasn't until like 1960, so 1970, when people started to link the enzyme problems, 1963, when the people started to link the enzyme deficiency being the cause of the Pompe disease. And it's not until almost 30 years later when people started to use or think about using enzyme replacement to treat those patients. So we're talking about 30 years between the first description of this disease, linking the enzyme deficiency to this disease, and then talking about or thinking about using enzyme replacement in human to replace this enzyme deficiency. Now, the pathophysiology, this is a biochemistry slide. We're not going to go back to biochemistry class, but this is one of the first pathway you learn during your biochemistry class. It's the glycogen glucose pathway. And just I would like to draw your attention to the very first enzyme in glycogen breakdown. This is a glycogenolysis, and that's the alpha glucosidase, the one actually deficient in Pompe disease. Other enzymes are involved in other glycogen storage disease like von Gerg and others. The hypothesis is really straightforward. You cannot break down your glycogen. So usually the muscle to use the glucose to produce energy, you have to break your stored glycogen to produce the
Dr. Ahmed, sorry, can you put it in a slide mode? Your slides, please.
Yeah, sure. Now it's clear. Okay. So now, you have to break down the glycogen to get to glucose and get your energy from the glucose. And what happens actually, so because you cannot break down your glycogen, the glycogen will be taken by a membrane complex or a transmembrane complex to the lysosome and will be stored in the lysosome. In the lysosome, where you're supposed to break down your glucose, you don't have this enzyme, the alpha glucosidase. The glycogen will be stored in the lysosome, and eventually with time, that actually will be accumulated in the lysosome and will disrupt the muscle function as well as the cardiocyte or the cardiac cell function. And that's what happened with time. So as you go on, as the patient grows up, the accumulation will increase time by time, day by day, until that will disrupt the muscle function mainly as well as the respiratory muscle function and cardiac function, especially in the infantile onset Pompe disease. And that's the story. So you have the enzyme, you have the glycogen storage stored there in an increased amount than usual, and you cannot break down that abnormal glycogen storage. How common is it? So all in all, it's 1 in 40,000. But if you divide glycogen storage, if you divide Pompe to infantile onset and late onset, infantile onset is 1 in 33,000 in Taiwan, 1 in 130,000 in Netherlands, and the adult onset or late onset Pompe is, we don't have a good statistics, but one Dutch study actually showed that in Dutch population, the frequency is 1 in 57,000. So it's not that rare. You will see it. We have a couple of cases in Saudi, and we will well, at least I have 3, 2 to be confirmed and 1 definitely confirmed, and he's on treatment. She's on treatment. Now, the phenotype. So we have different phenotypes, as I alluded earlier to. We have the infantile onset with a classical type or classic type of Pompe disease, and we have the late onset, which can be infantile or children or even adult up to 60 years of age. So it's really a very wide range of phenotype or presentation, and that's mainly depends on the amount of enzyme left in your body. So if you have 0 enzyme or less than 1% enzyme activity of the alpha glucosidase, most likely you will present as an infant with early onset Pompe disease. If you have somehow some of the enzyme left, anywhere between 1 to 30%, you will have a later onset. Scientists believe that actually you don't need to have you only need more than 30 or 35% of your enzyme to have a normal life, which is actually, it's a safety thing from Allah Azza wa Jal to keep that. Although we have a 100%, but you don't need that 100% enzyme activity. If you have 40, 50, that actually will give you more or less a normal life without any difficulties. So that's the problem with Pompe. It depends on the level or the amount of the enzyme or the activity on the enzyme left in your body. Now, starting with the first type, the classic type, the infantile onset, usually they present to your clinic as a pediatrician or neurologist between the first 1 to 3 months of age. And the common symptoms is feeding difficulties, hypotonia, failure to thrive, reduced, decreased movement, delayed motor milestone. And when you examine them, they have this axial hypotonia more than appendicular hypotonia, and they might have normal to reduced reflexes, but not usually absent like you see in spinal muscular atrophy, for example, which actually can mimic Pompe, infantile onset Pompe. Now, infantile onset, the main cardinal feature, in addition to the muscle, is actually the heart. So usually they tend to have heart problem, cardiomyopathy if you examine them, and that usually is a hypertrophic cardiomyopathy. Pompe is one of the few neuromuscle conditions that actually present with or cause hypertrophic cardiomyopathy. Most of the muscle disease actually usually cause the dilated cardiomyopathy. Very few can cause hypertrophic, and one of them is Pompe disease. It can affect the obstruction of outflow tract, and Dr. Jamil, our cardiologist, is going to talk more about the echocardiogram in fetus. But that's the thing that you can do. Even you can do an ECG, and that will show the hypertrophy or biventricular hypertrophy. Now, those patients, if you don't do anything, if you just leave them, usually they die. They die within like the first year of life, up to like 8 or 12 months of age. So usually they die due to either cardiac problem, the cardiomyopathy, or the respiratory failure, as well as the muscle. But usually the muscle will not. It's not the cause of death. It's mainly the heart versus the lung. Now, the non-classic type, the adult onset type, it has a very wide range of presentation, from either birth, but it's not your classic type, to up to 60 or 62 years of age. So that might make it difficult for you to diagnose those patients. You might have a 16-year-old with mild muscle weakness, you have a 6-year-old with mild muscle weakness, and you might have a 45-year-old with some difficulty with walking. So it can be, all of them can have Pompe disease due to the enzyme activity level, as I discussed earlier. So the possible presenting symptoms, they might not have all of that. Difficulty with proximal muscle. So usually they tend to have limb girdle muscular weakness. So usually they have problems with getting up from the floor, climbing upstairs, combing their hair, those kind of proximal muscle function. Fatigue is very common. Muscle cramping is there. It's not very common like myocardial, but you might see muscle cramping on Pompe, and respiratory failure. So those patients with late onset Pompe, they might actually present to the pulmonologist before even seeing you as a pediatrician, internist, or neurologist due to lung problem or recurrent chest infection or difficulty breathing, those kind of things. So the lung involvement or the respiratory muscle involvement can come even before the muscle weakness being evident on exam. Now, when you examine them, they have the proximal muscle weakness. They might have respiratory or early diaphragm weakness if you do the diaphragm ultrasound. Just to summarize, we have the, again, you have to keep Pompe always in your mind when you examine a child or a baby with hypotonia and heart problem, or an older children, or a child with, or an adult with some weakness. Few things in infant, always look for the heart, and adults or older children, always look for the respiratory plus the muscle plus or minus the heart. Heart is not usually a major problem in late onset Pompe. So that's your typical X-ray, axial head lag or axial hypotonia, and your typical ECG findings. And that's your typical Gower sign or modified Gower sign due to proximal lower limb weakness seen in patients with proximal weakness. Now, a few notes about late onset Pompe. As we said, is due to the low level of enzyme activity seen in those patients. Usually, cardiac is not a major issue. Usually, they don't have any cardiac. Usually, we say if the patient passed the first year or survived the first year of life without having any cardiac problem, usually they will have fine cardiac function without any problem later on. But that there is always an exception. But as a general rule, if you survive your first year, most likely you have a late onset Pompe with no major cardiac involvement. And as I said, it can look like a limb girdle for those neurologists or neuromuscle in the audience. Limb girdle muscular dystrophy is really one of the common differential diagnoses for adult onset Pompe. These are the muscles. I'm not going to go into details, but again, for the neurologist, neck flexor weakness and thigh adductor muscles are commonly involved, early involved in those patients. So always don't forget to examine the adductors in the thigh, and also the neck flexion when you examine your patient. Paraspinal muscle is another muscle that's commonly involved. You can see on the left side of the screen, there is a very atrophied paraspinal muscle where the white arrows are. And that's on the other side of the screen, actually the normal paraspinal muscle. And that's what actually gives them the scoliosis later on, scapular winging, those kind of back problems. You might need to involve orthopedic surgeons later on. That's your typical scapular winging seen in adult onset Pompe. Other non-neuro symptoms that can present, or non-cardiac symptoms. So in infantile type, you have hearing deficit, dysphagia, or difficulty swallowing that will lead to failure to thrive and poor weight gain, macroglossia, especially in infantile onset Pompe. And again, in late onset or non-classic type, they commonly have actually constipation, GI problem, reflux. They might actually need to see a dietitian or even a gastroenterologist. Vascular aneurysm, especially aorta, is not uncommon. So always keep that in your mind. And then they might have facial symptoms, especially ptosis, can actually confuse you with other congenital myopathies and other metabolic myopathies. This is your typical biopsy. We don't do biopsies in as frequent as before, but what you look for is vascular changes. There's a vacuole in the muscle, and when you do the acid phosphatase stain, which is the slide B, you can see the lipofuscin or the glycogen deposit in the muscle. So how we diagnose patients with Pompe disease? The first thing, actually, you have to keep Pompe in your mind. Yes, it's not very common. It's not you're not gonna see it on daily basis, but you come across a case every now and then. So always keep Pompe as a possibility in your mind. If you have, as I said, you have a hypotonic child with abnormal heart, always Pompe should be there. You have to screen for Pompe. If you have a late onset child, an adult or older children with muscle fatigue, mild weakness, slightly elevated CK, plus or minus respiratory problems, you have always to think about Pompe disease, but that's a late onset Pompe. How we diagnose? You can do an enzyme assay. You can do the genotyping or the gene sequencing of the GAA. Then there are other things that we'll talk about later on is something can affect the phenotype or affect the response to treatment. Sometimes you have to do it either early on before you start the treatment, or at some point during the treatment, you have to look for CRIM status, genotype, phenotype prediction, and antibody titers, those kind of things that can affect the patient's response to treatment. Other workups that we talked about is so CK, so usually it's either normal, but most of the time it's slightly elevated. We're talking about it should be around like less than 1,000, more or less. Sometimes can be like 1,500, but usually it's not a Duchenne level. It's not like 6,000, 15,000. Usually anywhere between few hundreds to like 1,000 or 2,000 maximum. We do a dried blood spot to diagnose those patients. Then we can do the GA activity, which it used to be the main way to diagnose those patients before having the ability to sequence the gene. Now, electrodiagnostic, for the sake of time, I will skip this. If you are interested, we might have another lecture later on in a couple of weeks about Pompe disease, but there is a specific finding in an EMG nerve conduction for Pompe patients. So something to keep in your mind. They have myopathic changes as well as evidence of irritable myopathy. And also something specific for neurologists, they might have myotonia on EMG studies, but although clinically they don't have myotonia or delayed relaxation of the muscles. Now, MRI, if you have the luxury to do an MRI muscle, you can do an MRI looking for the pattern of muscle involvement. And as I said earlier, the adductor magnus, your adductor, thigh adductor muscles are commonly involved, as well as other thigh muscles. The second one to be involved is the biceps femoris, the knee flexors muscles. Then other muscles, definitely, as the disease progresses, most of the muscles in the thigh will get involved. This is the typical MRI seen in patients with Pompe disease. Now, you have to confirm your diagnosis because we have a treatment, the enzyme replacement. You have to confirm the diagnosis. So you either to do a sequence the GA gene or to do the enzyme assay. When you sequence the gene, you most likely will have different mutations. More than 20 mutations have been found or reported to be linked to Pompe disease. I mean, there is a big list. You can review that if you want. I mean, again, I will pass this for the sake of the time. Now, let's focus on the treatment and have a couple of slides left to talk about the treatment. So, yes, we have a treatment for Pompe disease. Maybe it's not the best treatment, but we do have treatment, especially for infantile onset as well as late onset Pompe disease. But this success story did not come with an ease before it. So it's really preceded by a lot of hard work, a lot of failures before reaching to this conclusion of having an enzyme replacement therapy. If you remember when I talked about the history of Pompe, people did not think about using the enzyme until like 1963, when they actually linked the enzyme deficiency to the disease. So the theory of, okay, let's try to replace this enzyme came out to the world. Okay, let's try to do that. But they use actually fibroblast or cultured muscle fiber. They haven't done any human studies yet back then. And they tried to replace this enzyme. And they did do that. You can see here, A is before enzyme replacement. These are the muscle fibers, and B and C like few hours after, 16 hours, and like a couple of hours later. But again, that was not enough to restore the function of the muscle. So people are still trying and were struggling with how much you need to give, how frequent you need to give those treatment until like 1999, when the first human trial study actually came out, and they started to use enzyme replacement. They use the enzyme itself to replace the deficient enzyme in the human. And the first study actually came out to the public was in 2007, 2006, when actually they did the infantile onset Pompe. So they started with the infantile onset, and their primary outcome back then is, if you remember, we said like, if we don't treat, they die. So the primary outcome was, can we actually keep them alive? So that's the first thing that they were thinking about. Then, if we cannot keep them alive, can we improve their lung function as well as motor function? But the lung being the most common cause of death, so that's a second primary outcome. So actually, they did that. If you looked at the study, all the patients treated, infants treated with less than 26 days of age, they treated with enzyme replacement, actually they survived. So that actually they changed the natural history of the disease. Most of them die within the first year of life. Now all of them actually survived with the enzyme replacement. Not just that, even the lung function. If you see B and C, the curve B and C, so yes, all of them actually were alive. But in addition of that, you can see most of them, they were free of invasive ventilation. So we're talking about BiPAP or a tracheostomy tube. And not just that, even some of them, less, but not all of them, but some of them, they were free of even using any kind of supported ventilation. So yes, they changed the natural history. I have to admit though, not all the patients in that trial did response. So they had good responders and they had non-good responders. So, I mean, just to give you a clear picture, but again, most of them, they survived the disease. So that's really a life-changing history. But you can see this is actually the first 17 patients treated with enzyme replacement as an infantile onset Pompe. You can see a couple of no's here. Those are the patients, they were not able to achieve milestone. What I'm trying to show here is most of them survived. Most of them actually, they had a better cardiac function as well as lung function, but the motor response wasn't the greatest. So that's one of the first limitations seen in enzyme replacement therapy. It has a good penetration to the heart muscles, but for some reason doesn't have a good penetration to the muscles, the myocyte. Yes, they did get better, but again, most of them actually, some of them, they were not able to achieve milestone. Now that's the enzyme, the myozyme. It has been approved, FDA approved, back in 2006, based on this first infantile onset clinical trials that I just presented. The myozyme is very simple theory. I mean, it's a smart idea, but it's honestly, when you try to read it or think about it, it's very simple. They don't enzyme. You try to give them this enzyme. The enzyme will bind to the mono 6-phosphate, will go to the lysosome where they said the glycogen actually is stored, and the enzyme will go there, will help the glycogen, will help you or the cell to break down the glycogen. Then the glycogen will be transformed to glucose, and you can use glucose for energy. So it's very simple. It's not that difficult. But again, when you apply this in theory, it's not that simple. I mean, theoretically, it's easy, but when you apply it, we have a lot of obstacles. Scientists have faced a lot of obstacles to achieve a good or the perfect response to this treatment. Now, late onset Pompe, so after this successful story in infantile onset, the clinicians and scientists thought, okay, let's think about late onset Pompe. And they did that, the first randomized study of algoglucosidase or the enzyme replacement in late onset Pompe. This is their inclusion criteria. So more than 8 years of age with the confirmed diagnosis. They had a walking distance of more than 40 meters on 6-minute walk, one of the outcome measures we used. They had the forced vital capacity, and they had leg weakness. The exclusion was any patient on invasive ventilation or non-invasive ventilation. So that's important to mention here. And the primary endpoint was more or less the same, but here, because usually they don't die, they might have difficulty in their life, they might have respiratory issues. So the outcome is the primary outcome was not survival, but actually was the muscle function and the respiratory function. So the distance on 6-minute walk test, as well as the predicted change in the forced vital capacity. The secondary endpoints was any change in the quantitative muscle testing, the exam itself, as well as in other respiratory measures used by our colleagues in pulmonology. And just to keep it very simple, there was a clear, significant statistical difference between the treatment group and the non-treated group. They had a total of 90 patients, 60 were in the treatment group, and 30 was in the placebo group, 2-to-1, the typical randomization ratio. And you can see there was a clear response or significant p-value in changing the walking, the 6-minute walk test, as well as the forced vital capacity. And based on that, again, the FDA actually approved the enzyme replacement therapy for late onset Pompe. So now we have a treatment that is approved for both infantile onset and late onset Pompe. The enzyme is a bit different. The name is a bit different. So the first one is myozyme. Then we have lumozyme. It's more or less the same. It's really the dosing is different for adult or for older children and for the infant. Then, I mean, subsequently, studies have been done to look for the long survival and long-term outcome. And actually, this is a study of more than 430 patients or so of treated patients, treated Pompe patients. And first of all, in the left side of the screen, you can see the change in the forced vital capacity. So the ones in red, those are the treated patients, more than 400, as I said. And the one in dark yeah, I think dark or gray, it's the one untreated or natural history of Pompe patient. You can see with the FSC, at least you have some sort of stabilization. And on the 6-minute walk test, the muscle function, you have actually improvement in the function, not just stabilization. And that's again against or the opposite of what we see with the natural history of Pompe, of late onset Pompe. They keep declining with time if we don't do anything. Limitation. I already mentioned or talked about one limitation of this study is the muscle or myocyte penetration. So it has a better cardiac penetration than a muscle penetration, but it has other limitation. One is chemostatus. How much fibrosis in the muscle you have before starting the treatment, especially in the late onset Pompe. Antibody response. Now we're talking about there is an antibody against this enzyme that actually might break down this enzyme before reaching the lysosome to do its job, and we don't have a CNS penetration. Now, I'm not going to spend a lot of time on this, but hopefully in a different time, a different lecture, but CNS penetration. So this is one thing actually, we believe It's a Pompe, it's a muscle disease, yes, but also has something to do with the motor neuron and the muscle based on the EMG studies and nerve conduction study. So people think, or scientists think, if you have a better CNS penetration, you will have a better motor function, motor neuron function, and eventually will have a better nerve than muscle. So that's one of the limitations of this study. It does not cross the blood-brain barrier. How the scientists thought about overcoming these limitations? Dosing. So this treatment is given every 2 weeks. It's an IV infusion. Dose anywhere between 10 to 20 mg per kg. But people thought about, okay, can you give it weekly? Can you double the dose? Can you think about how to change the dosing regimen to overcome this? They were successful to some degree. They talk about chaperone therapy. So we talked about muscle penetration. So can we give another medication at the same time to help this treatment to reach to the muscle? And if we have an immune response, can we somehow give an immune medication or steroid before giving this treatment? So these are some of the ways they try to do to overcome the limitations. Finishing up with this, so it's gene therapy. So gene therapy is really a new thing that everyone is talking about gene therapy in genetic disorders. Pompe is one of those genetic disorders they can use gene therapy for. It's a very straightforward monogenic disease. The idea of the gene therapy is what you are trying to do is, now we don't have a GA, we have a deletion or mutation in the GA gene. What you're trying to do is to bring this GA gene, give it to the patient, find a carrier or vehicle that you can put the GA gene in it and deliver it to the patient. The GA will go, or the vehicle will take this GA gene to the muscle, to the cardiac side, the cardiocyte, the cardiac muscle cells, as well as the CNS or the motor neurons, and that will start, the gene will start to replicate itself. So the most commonly used vehicle is adenovirus, adeno-associated virus. Why? Because it's easy to engineer this virus. You can take the infectious particle out, and you can put the gene of interest in that virus, and you give it to the patient. So it doesn't have any infectious ability. And that the other thing good about this virus, you can enhance you can promote the transcription like an HIV virus. So the virus will go in and will start to replicate, and by replication will produce this missing protein. This treatment, this theory has been used and already FDA approved in SMA, for example, spinal muscular atrophy. In one of the hereditary eye disease, we have another FDA approval treatment. In Duchenne, people are talking about the gene therapy. So it really is coming over the next couple of years. Most likely, we're going to have a gene therapy for Pompe. We have a couple of companies working on that, including Sarepta and others, trying to come up with a gene therapy to give it to the patients with Pompe disease. Lastly, newborn screens, so especially for infantile onset, we don't have that.
We're running out of time, please.
Sure. Yeah, I'm finished. So this last two slides. So something to keep in mind is the newborn screen. Just to end up, always keep in Pompe disease in your mind. If you're seeing a patient, an infant with hypotonia and cardiac problem, always keep it in your mind. If you're seeing an older child or an adult with proximal weakness or limb girdle type or phenotype weakness, as well as recurrent respiratory problems, you can easily do your testing by starting with the CK. Then you can do the dry blood test or spot for enzyme activity, or you can sequence the GAA gene to find your answer. And now, if you have that, we can always contact one of us or the metabolic doctors or the geneticists or even the company to help you to start the enzyme replacement. We do have a couple of patients in Saudi receiving enzyme replacement. Well, it's not a lot. I believe we are underdiagnosing late onset Pompe, but we're trying to bring the awareness up. So everyone, please keep that in your mind. You can change the life of a patient by starting the enzyme therapy. And thank you.
Thanks, Dr. Ahmed, for this marvelous presentation. Now our second presentation is Fetal Echo by Professor Dr. Gamil Al-Ata. Dr. Gamil is Senior Pediatric Cardiology Consultant and Associate Professor at King Abdulaziz University Hospital, Jeddah. Also, Dr. Gamil is Senior Pediatric Cardiology Consultant at King Faisal Specialist Hospital and Research Center. We would like to welcome Dr. Gamil, and please, you can start now, Dr. Gamil.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Abir. Thank you, Dr. Fawzia. Thanks for Saudi German group for inviting us to this webinar. I hope our audience and attendees will find it beneficial. Thanks, Ahmed. An excellent presentation on Pompe disease, something us, the first generation kind of cardiologists do not see that much. But I remember the first time when we had some gene therapy for such patients, it was really a big failure, and that was around 2007, 2008. So I'll be talking about the role of fetal echocardiography in congenital heart disease, and I'll touch on some of its impact on genetics. We all know that the incidence of congenital heart disease is around 8 per 1,000, around 1%, and it's slightly higher in the fetus population, 1.5%, and this is because some of those fetuses are actually lost in the first 3 months of pregnancy because of the severe malformation. Nearly all types of postnatally diagnosed congenital heart disease were also diagnosed prenatally. So fetal echo today can really give you a very correct diagnosis of the congenital heart disease or other diseases. I mean, we were talking just a while ago about Pompe's disease, and myocardial hypertrophy and dysfunction is something that we evaluate carefully in fetal echocardiogram, especially knowing that we get referred those patients with non-immune hydrops. The more complex the in utero congenital heart disease, the more easily diagnosed, and the simpler, the more missed. So we definitely can miss an ASD because fetuses do have a foramen or oval, which is open. We miss mild aortic stenosis because of pressure differences. We miss mild pulmonary stenosis. But again, these are not important diseases that you really want to know about, and many can pass throughout their life with no issues. Some congenital heart disease types are shown to evolve and progress in utero, and valvular aortic stenosis is very important. And here is one important role of fetal echo, really to show us the nature of the disease. And we know some diseases like valve PS or valve AS, aortic stenosis or pulmonary stenosis, can cause or can progress and cause ventricular hypoplasia. And as such, nowadays, there is even some interventions for them to prevent ventricular hypoplasia. Anything between 20 to 48% of in utero heart disease, congenital heart disease, is associated with congenital anomalies. So about 50% can be associated with chromosomal anomalies in utero, and that's not correct for the postnatal CHDs. Which is only about 10%, and 20% with extracardiac anomalies. Just remember, the heart has all the layers, the ectoderm, the mesoderm, the endoderm. So the heart is commonly involved in most of the systemic diseases. And we saw how Pompe affects the heart because it's a muscle. If you have a disease that affects the skin, it can affect the heart because it will affect then the conduction system and so on, or the mesoderm if you have a more congenital disease that affects your connective tissue. Fetal echocardiography is quite an accurate diagnostic tool for congenital heart disease, up to 90% sensitivity and up to about 100% specificity when using the state-of-the-art ultrasound technology and pediatric cardiology fetal medicine collaborate. So again, you cannot do fetal echocardiography with just regular simple ultrasound machines. It has to be or it has to have the software for fetal cardiology. Routine obstetric ultrasound is not a good screening test for CHD. It is both late because a lot of the time, although today it's being done a bit earlier by many of our colleagues, but usually it's done for the high-risk patients. That means they would do it around 14 to 16 weeks. But again, it's limited. And that's why we used to miss quite a bit of congenital heart disease. Today, it's more comprehensive, and our colleagues in fetal-maternal specialties are actually now looking at the heart in a more elaborate way. Indications for fetal echocardiography are many and not limited to what I'm going to mention. Diabetes insipidus can be, diabetes mellitus can be associated, maternal diabetes can be associated with so many things other than just the hypertrophy, but also congenital heart disease, infections, in utero infections, teratogen use, if the mother has received any medication, then yes, we would like to screen the heart. One common referral or indication is just an abnormal 4-chamber view. And a lot of the time we get a referral for a smallish RV. It turns out to be just a foreshortened cut in the regular ultrasound. But again, any suspicion of the heart should be referred for a fetal echo, just because diagnosis is quite important and postnatal management is quite important, along with the counseling of the parents. I just received recently a baby or fetus who was diagnosed with Klinefelter syndrome by chromosome analysis. The chromosome analysis was done for something else, for possible chromosome 13 issues, because the family had family history. And for surprise, they found that the patient actually has Klinefelter syndrome, and was referred for CHD rule out. Chromosomal abnormalities for sure, any extracardiac anomalies, dextrocardia, situs inversus, fetal growth retardation, and fetal arrhythmia, and obviously fetal hydrops. These are just numbers to show you the sensitivity of ultrasound malformation. For central nervous system, 88. For cardiovascular, you see how it's really not so good. Urinary tract is quite good. So the ultrasound, just the prenatal ultrasound, is quite good for central nervous system. For urinary tract and others is not as great. And here is why we need the fetal echocardiography, which actually today can be done by fetal-maternal experts, not just the pediatric cardiologist. Accuracy of prenatal diagnosis of congenital heart disease. This is just to show, these are studies showing the different sensitivities and specificities. And you can see it's quite good. The numbers are all above 90. This is just to show you the typical 4-chamber view of a fetus heart. It's an upside down view. This is the right ventricle with the moderator band, left ventricle, smoother ventricle, the tricuspid valve, which is slightly lower down, and the mitral, which is higher. And you can see the aorta there and the pulmonary veins. This is the upper pulmonary veins, lower pulmonary veins coming in. And this is the foramen ovale. So you can really see the heart. And usually we see the heart in the very, very good when the baby is over 16 weeks of gestation. This is the arch view of a fetus, or which I like to call the cane sign. And you can see the aortic arch with even the 3 branches of the vessels. And this is because we cardiologists take the conus, or the base of the heart in consideration when we look at the heart, and we include the great arteries and the base of the heart, and that's why we get much more yield out of it. The regular ultrasound does not include this one, and if it really does, then a lot of the malformation can be actually taken care of. This is just to show you a common finding, just a tiny muscular VSD, nothing important to report, but it's there, it can be seen. And this is it in color Doppler. Obviously, cardiologists are much more accustomed to using color Doppler. And again, if fetal-maternal specialists get used to it, you can actually detect shunts. And shunts are quite important to show defects, although pressures can be equal in both ventricles, and a shunt may not occur, but occasionally you can see it and confirm the diagnosis. This is a patient with transposition of the great arteries. You see, if we stop just to the 4-chamber view, no one will see the great vessel. But once you go to the great vessels, you can see easily that this is the left ventricle, which is the posterior ventricle, giving the artery that branches into 1 and 2. So this is the pulmonary artery, and that's the aorta. So very explicit example of diagnosing transposition, which can affect management quite a bit in the postnatal period, and makes it easy. We just 2 days ago, a baby was delivered in the car actually, and became cyanotic, referred, and was found to have transposition. If this baby was diagnosed prenatally, it would probably been delivered properly in a tertiary center where he could get the treatment properly. This baby today is not doing well because, again, was left to be cyanotic for a long time and acidotic. So fetal echocardiography, or looking at the heart in detail, whether by fetal echocardiography or through fetal-maternal experts, can make a big change. What is the impact of fetal echocardiography? On epidemiology, we can actually diagnose more. So it is one of the tools for screening for congenital genetic diseases, and that's why it's here in this talk or in this webinar today. Malformations due to pregnancy termination through incidence of congenital heart disease is around 1%, which is about 4% higher than the detected postnatally. Up to 48 of in utero heart disease is associated with chromosomal anomalies. Possible decreased prevalence of CHD associated with severe extra cardiac malformations. So these are findings that fetal echocardiography could provide. In a recent study, 149 fetuses with heart disease, congenital heart disease, and normal karyotype were analyzed. 76 fetuses had conotruncan anomalies. Imagine it's 149, so let's say 150, and this is about 70. Half of them have conotruncan anomalies. That means you really have to include the base of the heart and the great vessels to be diagnosed. And these are actually, or usually, the severe lesions that can die within the first week or month of life if not diagnosed. Chromosome 22q11 deletion was present in 10 cases, about 77%, all of which with truncan anomalies, you see. So DiGeorge syndrome can even be diagnosed by just knowing the conotruncan disease or anomaly or CHD anomaly. Thymic hypoplasia or absent thymus suspected in 11 cases with conotruncal anomaly. Again, DiGeorge. 9 of these 11 had deletion. 2 cases were false positives, so not all of them carry the same deletion. 1 fetus with a normal sized thymus had deletion, so proves to us what we already know, that it is not always that the thymus has to be hypoplastic in these conotruncal anomalies. On fetal neonatal well-being, the impact of fetal echocardiography, one very important one is a timed delivery in a tertiary center. And tertiary center here does not mean or need to be a cardiac tertiary center, but at least a center with excellent neonatal modern services where cardiology can be consulted for any for diagnosis for sure, and for management and further bedside intervention like a balloon atrial septostomy if needed. Decreased morbidity and perhaps better long-term outcome of infants with semilunar valves obstruction. We know that left-sided obstruction, especially aortic stenosis, or the forms of variable forms of hypoplasia of the left side, these are the babies or infants you want to pick up immediately, and you want to start prostaglandin immediately. You don't want them to go into cardiogenic shock and then start treating, because then the outcome may be quite poor. Intrauterine treatment, fetal arrhythmia is a great example. It's been ongoing for a long time now, treating fetuses, giving the mother the antiarrhythmics, and this is a whole talk by itself. And maybe one time we can invite Dr. Khadija Maghrabi, the pediatric consultant electrophysiologist from University Hospital, to give a talk on that. Monitoring fetal well-being during the maternal treatment is quite an impact. Not only that, monitoring fetal well-being with other issues, non-cardiac, from the cardiac point of view, just making sure that the heart is okay, beating is okay, function is okay, atrioventricular valves, mitral, tricuspid are not leaking. The patent foramen ovale is quite adequate. All of these things, fetal echocardiography can help in the well-being of the baby. On management, we can better prognosticate and counsel parents and plan all the management prenatally. See, we always say that the womb or the uterus is the best place for the cardiac fetus. And if you want to really to plan a management, it's better to be on the fetuses inside, not outside, because then you may be pushed by the acuteness of the illness or the time that you have to do the treatment for pain. Pregnancy termination at appropriate time, if that's allowed legally and religiously, especially if it's associated with other extracardiac anomalies or lethal chromosomal abnormalities. Better understanding of the pathophysiology and evolution of congenital heart disease. It affected us and told us how really and when to start treatment. And that only happened really when we started to do more fetal echocardiography. How to get a real impact from fetal echocardiography. Fetal echocardiographic screening between 11 to 14 weeks of gestation. So our colleagues from fetal-maternal really have to get in and hop in the wagon, as they say, and start doing it, because they can do intravaginal ultrasound and see the heart. And if they are more accustomed at echocardiography, a lot of these diseases can be diagnosed, and hence fetal outcome and maternal well-being will be better. Screening both low risk and high risk pregnancies. It's not useful just to say that fetal echocardiography is for the high risk pregnancy. Well, high risk pregnancy will get attention for sure, but all pregnancies should be screened. The heart is a major organ with major malformations, so it deserves a good study, like when you look at the ultrasound, like when you look for the kidney for hydronephrosis, or the brain for hydrocephalus. And we saw how ultrasound was so good in those two systems, and it has to start matching for the heart. Developing markers may be something to talk about. Collaboration and the use of state-of-the-art ultrasound is a real important thing. So fetal-maternal unit technology plus cardiology can really make a big difference in the outcome of fetuses with congenital heart disease. Including the ventricular outflow tract I spoke about. So the outflow and the base of the heart should be included in the study. Training technicians to do so. We know that most ultrasounds, obstetric ultrasounds, are done by technicians. And it's not good just to have the doctors being aware of congenital heart disease. If we train our obstetrical technicians, we will start getting more incidence and better outcome. And develop safe intrauterine interventional procedures. In Saudi Arabia, there's one center that does intrauterine cardiac intervention, and actually they just published their few cases recently, which is Prince Sultan Cardiac Center in Riyadh. And this needs a good drain and referral from our colleagues in obstetrics and fetal-maternal, so these cases can be detected early and intervened on in a proper time. In conclusion, fetal echocardiography main impact is really on detecting the incidence or knowing the incidence and appropriate prenatal and perinatal treatment. It is a demanding yet promising tool. Today it's really much less demanding. Sequential studies are needed to track evolving lesions. Limitations include operator level of expertise, technology, nature of the congenital heart disease, number of collaborating centers, and level of awareness. I just want to finish by saying that we can detect in fetal echocardiography the diameter and the thickness of the heart, and that's quite an important thing for other non-congenital heart disease involvement of the heart. Thank you so much for your audience.
Thanks, Dr. Jamil. This is very marvelous presentation and very important in our practice. Now we can start the questions, and please, Dr. Fawzia, you can start.
Assalamu alaikum again. Thank you, Dr. Ata. Thank you, Dr. Bamaga, for those nice presentations. Now we are ready for some questions or comments. I will get the questions. Dr. Ahmed, I think in our practice, I did make not a lot of cases, around 3 cases of Pompe disease. I did start enzyme replacement very early, but there was difficulty in getting the CRIM status. It seems that the genes mutated in our region is severe type. And as you know, we share one case of Pompe disease and myasthenia gravis in our hospital, Saudi German hospital. The outcome, hoping it will be more improved in the future. So do you have cases that benefit from enzyme replacement therapy?
So in Saudi, we shared this case. I mean, but the problem in the case we share at Saudi German Hospital, she also has the myasthenic syndrome, congenital myasthenic syndrome. So we're not sure, I'm not sure exactly how much that actually is affecting the Pompe. She's getting better, but I mean, very slowly, baby steps. But I mean, during my fellowship in the state, we had a total of 12 patients infantile onset, and they were receiving the enzyme replacement therapy. Actually, they did like a newborn screen. So in the state, we have like, I think 4 states now, they do the newborn screen for Pompe, including Missouri and Washington state. And they picked up, most of those patients were picked up as a neonatal newborn screen and started the enzyme replacement therapy in the first 2-3 weeks of life. And if I remember correctly, at least 11 of them, they were having normal heart function. So they're followed by the cardiologists there too, and they were doing fine. Not all of them were doing okay from the muscle point of view, from the motor development point of view, but cardiac-wise, they were doing completely fine. So what I can say, one, yes, our mutation is a bit different in the MENA region or the Gulf area than the one in the Caucasian population. It seems, as you just said, our mutation is a bit severe or more severe than the others. Two, it's really the CRIM status. I mean, we don't have the ability, or it's not really easily done here in Saudi. You have to fight for it to be able to get the CRIM status. We know that, I mean, if you have CRIM positive, CRIM negative patient, they actually tend to respond poor or less than the CRIM positive patients. I think, I mean, for the cardiac function, yes, the improvement is there. For the muscle point of view, I think we need to work more on the enzyme replacement and find another way. Hopefully the gene therapy will be a better way to treat.
Thank you, Dr. Ahmed. I have another comment or question. Do you think you have undiagnosed cases of myopathy for Pompe disease? Should we screen all patients with myopathy if there is no diagnosis, definite diagnosis for Pompe disease?
I mean, for late onset Pompe, I think yes, especially if they have, especially if they have high CK or slightly elevated CK. I think it's very important. In one of the study, actually, they looked at the high CK or hypercemia patient in Children's Hospital in Boston with hypercemia and diagnosed patient. I think 5 to 7% tend to have Pompe, late onset Pompe. So I think we are underdiagnosed those patients. It's not, I mean, I think now we're having, the test is more readily available. The company is helping with providing the test. But I agree with you. I think those patients undiagnosed, we should, especially with high CK, mild weakness, we should entertain the possibility of Pompe disease.
Actually, we have one group called MENA group. We did a publication regarding the protocol for management of late onset Pompe disease.
Great.
Okay, I have Dr. Jamil. I have some questions for you, please. Can cardiomyopathy be diagnosed in fetal life? Dr. Jamil?
I think yes. The answer. Yeah, I can hear you, Dr. Fawzia. Thank you. For sure, yes, it can be diagnosed, especially hypertrophic types. One of the fetal echocardiography role and routine exam is that we, in the short axis view, we take LV posterior wall, interventricular septum, and RV free wall thicknesses. And anything approaching 4 millimeter or more, we consider hypertrophy, and these patients can be followed. Indirect evidence of diastolic ventricular dysfunction is a routine thing in fetal echocardiography. We do inflow Doppler patterns and check the E waves and the A waves expected pattern, if it's reverse, if it is equal, if it is not. And also, for sure, AV valve regurgitation and ventricular systolic function. So the answer is yes. And actually, this is a mainstay of fetal echocardiography. And we do that quite routinely in all studies, with more emphasis during when we get referred the fetuses with high drops.
So you think if there's a family history of Pompe disease, we should refer all the cases for fetal echo? It might help in diagnosis.
If there is I'm not sure Ahmed will let us know, is there such a thing as fetal Pompe diagnosis? Are we going to reach that? If the patient, I suspect that if I get a referral, it would be more like we saw the heart hypertrophied or more high drop, not specifically Pompe's. I'm not really aware of in utero Pompe's diagnosis unless there was something that actually provoked that, and chordal or villus sampling was done for it because of something that provoked it.
Ahmed, you have any comment?
So no, I agree with Dr. Jamil, and I think Dr. Fawzia might have more experience, but yes, I mean, not all patients. So the thing with infantile Pompe, there was one study looked at fetal echo in Pompe as a tool to diagnose prenatally diagnosed patient with infantile Pompe, and they found actually, yes, most of the patients, they tend to have hypertrophic heart even during fetal period, but some of the patients did not have hypertrophy. So what I'm trying to say is having normal fetal echo does not rule or exclude fetal or infantile onset Pompe. But I think it's a good way. I think it's easier than fetal echo is to establish a newborn screen for those patients with family history.
Yes. Yeah. Yes. Thank you, Dr. Ahmed. There is another question for Dr. Atta. What cardiac treatment can be delivered to the fetus?
Well, thank God our fetal-maternal colleagues have developed so much of these interventional procedures to the fetus. They now can go deeply into organs and treat them. And the heart is not something away from that. We collaborate with our experts, interventional fetal-maternal colleagues, to reach especially semilunar valves, and go with wires and put a balloon, like a cardiac cath, completely cardiac cath done under ultrasound. And balloon dilate an aortic valve, balloon dilate a pulmonary valve, deliver specific therapy. The most therapy that can really be delivered is anti-arrhythmic treatment for those fetuses, and that is really where fetal echocardiography and really diagnosing the specific type of arrhythmia through atrial and ventricular interrogation and knowing the type of rhythm, and then consulting with EP to give the specific treatment. These are kind of the treatments that can be delivered today to the fetus cardiac-wise.
Okay, there is another question, Dr. Ahmed, if you can answer this. The question is, if there is no cure for Pompe disease by enzyme replacement therapy, what kind of other therapy we can offer for such patients?
So, I mean, yes, it's not a cure. The enzyme replacement therapy is not a cure, but actually it does change the life, especially if you started early for infantile onset Pompe, because as we said, if they don't survive, if you give it early, they survive. But again, it's not a cure, it's a treatment that can help. But now I think it's a good opportunity to talk about, even with enzyme replacement therapy, or even if we have the best treatment option, you have to apply the standard of care. So you have to look at those patients from the holistic point of view, like dietitian point of view, orthopedic if they have scoliosis, pulmo point of view if they have difficulty with breathing. So you have to apply all the standard of care measures to assure the response to treatment. Now, if we talk about specific treatment, we are hoping, like everyone else, that hopefully once we have the gene therapy, that actually will turn the corner around, and hopefully will have a better outcome. after the gene therapy. But that's again, I hope, and hopefully within the next couple of years, we'll have more and more information.
Thank you. There is a question from Dr. Yasser Hussein for Dr. Ata. Is Pompe in fetal life could develop hydrops fetalis?
Well, I'm not sure if it can, but I would suspect yes. Any severe hypertrophy of the heart, regardless of the cause, and diastolic dysfunction can give hydrops. And I would assume that Pompe is one of it. It's quite a rare disease to see and treat, and mind you, to find it in the fetus, but definitely any significant hypertrophy can evolve into a fetal hydrops, and it is one of the standards that we look for in hydrops when they are referred to us.
Thank you, Dr. Ata. For Dr. Bamaga, there is one question. What is the typical standard of care for patients with Pompe disease?
Sure. I mean, I think I just mentioned some of those typical the standards of care that we usually use, but those patients really need a multidisciplinary approach. I mean, it's not a single disease. It usually affects, as Dr. Jamil mentioned, the heart, the lung, the muscles, the GI tract, and as well as the bone. So you have to involve most of those patients or specialties when you treat those patients, as well as social support and family support, because it's not easy to look after a patient with some difficulties. But generally speaking, those patients need to be seen routinely. You have to apply outcome measures. They have to see the physical therapist, focusing on strengthening exercises, as well as maintaining what they have. And then they have to follow with pulmonology regarding the respiratory function, especially with the late onset Pompe. And for infantile onset, they have to follow with cardiology regarding their heart condition. So you really need a key person, like a pediatrician or internist, to be the person coordinating between different specialties.
Thank you, Dr. Ahmed. One last question for you. What do you mean by CREM?
What do I mean by CREM? Okay, so a CREM, it's another talk by its own, but CREM is a cross-reactive immunological protein or material that it's really an endogenous protein. If you have it, that means the patient has some residual enzyme activity. Even if the enzyme activity, say, showed that it's zero, but you have a CREM positive patient, that means there is something left, and you expect those patients to respond better to the enzyme replacement. If the CREM is negative, that means there is nothing, like zero protein produced by that enzyme activity, and most likely those patients tend to respond poorer than the other ones to the treatment. So it's one of the ways or biomarkers used to assess or to predict the outcome or response to the treatment.
Thank you, Dr. Ahmed. The last question for Dr. Ata. What cardiac lesions are incompatible with life?
Well, it's important. This question is important, not to really know what are compatible with life, incompatible with life, but really who are the ones where we can counsel the parents to say that this is probably a non-viable heart. Because in the context of fetal echocardiography, we get faced with so many other issues, a chromosomal anomaly, other cardiac non-cardiac malformations, and then the heart comes in, and we get the question, should I continue this pregnancy or not? What do I expect after? So severe lesions like hypoplastic left heart syndrome, which are diseases for life, and which have or carry a very high mortality, even with operations post-operative. I mean, only around 50% of these babies will reach the age 6 years old. So knowing such lesions or others like heterotaxia syndromes or isomerisms, where the heart and the visceral situs and the rhythm and the pulmonary veins are really extremely malformed. These lesions are important to detect early, because if there was a consideration to terminate before الخلق or before يعني بث الروح, then it is important to recognize these lesions, because they do represent a category where we can honestly and strongly say you are allowed to terminate, because it is a very severe cardiac disease that even post-natally may not have a good treatment. This is not to say that nowadays there is no good treatment for severe cardiac lesions, but today there is a lot of good treatment. And we do have some of those isomerism hearts, hypoplastic hearts who are adults today. But again, it's a very long journey with a lot of disease, with a lot of difficulties, with a lot of disease burden and family and social, whatever. So it's important to detect those quote unquote incompatible with life lesions for good counseling and prognostication.
Okay, thank you, Dr. Jamil. I think we don't have further questions. Thank you, Dr. Jamil. Thank you, Dr. Ahmed. Thank you for our moderator, Dr. Abir. Thank you for Saudi German Hospital. Thank you for the and audience. And we hope to see you next Friday for our third session, inshallah. Thank you, everyone.
Thank you so much. May Allah accept. Assalamu alaikum.
Thank you.
Assalamu alaikum.